Welcome to Community Health Briefs, where AI hosts share short, clear stories about research shaping healthier futures. Each episode highlights new work from members of the College for Community Health at Montclair State University, showing how ideas connect to the social and structural forces behind health. In short, this is research you can trust, explained by AI in minutes.
Have you ever felt unheard, maybe even mistreated, in a really high-stakes medical situation? Well, for about 30 to 40% of Black and Hispanic birthing people, that's actually their reported experience during hospital maternity care.
It's a shocking number, but here's the flip side, and it's crucial. When these same groups use freestanding birth centers, something like 85% report being satisfied, actually extremely satisfied.
Right, it's a massive difference, and that's exactly why we're doing this deep dive today.
Right. We're looking at research led by Dr. Becky Ofrane at Montclair State University, along with her colleagues Drs. Rakiki, Cantor, and Blumenfeld. Dr. Ofrane really focuses on, the systemic issues behind health disparities, especially in maternal health.
So our mission here is to figure out why these birth centers, which seem to offer a better, more satisfying experience for many, are so hard to access, particularly for low-income birthing people of color, say, in New Jersey where this research was based. What's blocking them, especially financially?
Exactly. What are the financial choke points holding this model back?
Okay, so let's unpack how they approached this. It wasn't just looking at numbers, right?
No, not at all. They actually talked to people. 16 experts deeply involved in the system. People running birth centers, folks from health insurance companies, state departments, policy groups, really getting the inside view.
A real 360-degree perspective. Smart. So what was the biggest takeaway?
Money. Plain and simple. The number one barrier. Inadequate Medicaid facility reimbursement rates.
Medicaid, which is huge because nationally it pays for the most births for women of color.
Precisely. So if the rate Medicaid pays a birth center is too low, the center just can't afford to serve those patients. It shuts down equitable access right there.
And the numbers here are pretty stark, aren't they? What was the rate in New Jersey again?
In 2023, it was around $1,300. $1,300 for an on-site birth.
$1,300. Wow. And how does that compare elsewhere? You mentioned Massachusetts.
Yeah, Massachusetts recently updated their rate to over $6,000.
$6,000. That's what, more than 4 times higher? For the same kind of care.
Exactly the same kind of care. And you can imagine the impact. One person they interviewed from a birth center said the New Jersey rates were so low, it wouldn't even pay for, the sheets.
Not even the sheets. That says it all, really. It makes it almost impossible to operate sustainably if you rely on Medicaid patients.
It basically forces centers to limit Medicaid or avoid it altogether if they want to keep the doors open.
Okay, so that's the reimbursement side. But what about just getting a center off the ground in the first place?
Another massive hurdle. Startup and operating costs. They are incredibly high. One center estimated their project cost at $5 million.
$5 million. For an independent midwifery practice, that's likely out of reach unless you have major backing.
Totally prohibitive. And part of the reason costs get so high is regulations. Things like mandatory hallway sizes, which makes sense for a big hospital maybe.
But not necessarily for a small community birth center.
Exactly. These hospital-centric rules often mean they can't use older, more affordable buildings. They're forced into expensive new builds or major renovations. Drives the cost way up.
So we have low reimbursement on one end and sky-high costs on the other. It's a squeeze.
A major squeeze. And then there are these other sort of indirect barriers that connect to the bigger picture.
Like what?
Well, the midwife supply, for one. Birth centers rely entirely on licensed midwives, but there's a shortage.
A shortage? How bad?
Pretty bad. One expert said, quote, "I would hire 1,000 midwives tomorrow if they were lined up at my door."
1,000. That points to a real bottleneck in training and getting midwives into practice.
Definitely a workforce pipeline issue. And this connects to another point. Patient demand.
Is demand low or is it changing?
It's actually growing significantly, especially among Black women.
Oh, interesting. Why the shift?
The study suggests it's driven by, and this is a direct quote again, long-term trauma related to medical racism experienced in hospitals. So birthing people of color are actively seeking out the birth center environment because it feels more comforting and supportive. They're seeking dignity and respect in their care.
So the demand is there, driven by negative experiences elsewhere. but the system isn't set up to meet it because of these financial and structural barriers.
That's the core of it. Patients want this option, but the finances just don't work under the current structure.
Okay, so pulling this all together, what needs to happen? What are the actionable insights?
Well, first, states like New Jersey need to regularly increase those Medicaid reimbursement rates. Not just a one-off fix locked into rigid legislation, but consistent updates that reflect actual costs.
Makes sense. Keep pace with reality.
Yeah.
What else?
Invest in the midwifery workforce. Seriously, invest. That means more training programs, better support, and crucially, diversifying the workforce. Supporting more midwives of color.
Why is the diversification so important here?
Because it improves racial and cultural concordance. Patients get care from providers who may share their background, their experiences. That builds trust.
Right, trust that might have been broken in other healthcare settings. It addresses the equity issue head on.
Exactly. So the big takeaway is this. Freestanding birth centers. They're a high-quality, cost-effective, and really equitable option for low-risk pregnancies. But they're fundamentally undermined right now by the systemic financial barriers, weak Medicaid payments, high operating costs. Fixing this is vital for maternal health equity.
It really is.
Yeah.
And it makes you think, if other states, especially ones facing similar challenges with maternal health disparities, really took a hard look at New Jersey's situation and decided to tackle these policy and money issues, how quickly could we change the conversation nationally about making safe, satisfying, equitable birth options truly available for all women? That's definitely something for all of us to mull over.
Thanks for listening to Community Health Briefs. This podcast was created with the help of AI, verified by the paper's author, and does not necessarily reflect the views of the College for Community Health or Montclair State University. Thanks again for listening, and stay tuned for our next episode. Make sure to subscribe and check us out at www.montclair.edu/CCHL to learn more about us and the amazing work we're doing for community health.